Hi everyone, welcome to day 2 of the BTAN Richmond and Petersburg 3-day science and treatment training. My name is Rebekah Israel and I'm the Training and Evaluation Coordinator at the Black AIDS Institute. First, let me start off by saying that I am so sorry that I couldn't be there. A lot of us were traveling for MBAT events this week, and schedules just got crossed, and so I was unable to make it this year. So I'm sorry that I missed seeing all of your beautiful faces this time around. I was there last year, and I met a few of you, I'm sure. And so next time there's a large BTAN training in Richmond, somebody from the Black AIDS Institute will be there. I can guarantee that. So again, let me welcome you to day 2 of 3-day science and treatment training, and I'll go ahead and get started with my presentation. So if I were with you, I would say something like, how many of you have heard of the Black AIDS Institute? And there would be a few people who would raise their hands, maybe half or a little bit less than half of the room would raise their hands. And then I would ask something like, if you can, in less than two sentences, can you explain what the Black AIDS Institute does? And then you would start seeing all of the hands go down. And so what my job here today is to explain to you what the Black AIDS Institute does and why there's a BTAN in Richmond, Virginia. Richmond-Petersburg, Virginia, sorry. So, the Black AIDS Institute was founded in May of 1999, and it is the only national think tank for HIV and AIDS that is focused exclusively on Black people. And then our mission is to stop the AIDS pandemic in Black communities by engaging and mobilizing Black institutions and individuals in efforts to confront HIV. And we do this primarily through 4 ways. We interpret public and private sector HIV policies, conduct trainings like the one that you're in right now, offer technical assistance, and disseminate information. We also provide advocacy and mobilization opportunities. And we do this all from a uniquely and unapologetically Black point of view. And so one thing that we like to share in all of our presentations is this roadmap here. And so it basically shows you at the top left corner where we are in the road to ending AIDS. And then at the bottom right corner, it shows you, that is where the AIDS epidemic will end. And so how do we get there? What's interesting is that, if you think about the trajectory of the history of HIV, we are far, far, far from where we started. So we have, much better diagnostic tools. We have certain testing technologies that can tell you, 11 days after exposure if you've contracted HIV. So our testing tools are much better. We have better surveillance tools. We have tools like, if you look at AIDSview.org, where you can see down to the zip code of what the AIDS epidemic looks like in a certain community. We have better treatment, we have better prevention, and we have better policies when you're looking at things like the Affordable Care Act, which essentially eliminated pre-existing conditions such as HIV from being rejected from getting health care insurance. And so why aren't we have all these new tools, right? So why aren't we at the end of the AIDS epidemic? Why aren't we there? And I'm sure there's some reasons that you all can think of, and there's a ton that I can think of, and there's only a certain number that we can actually focus on here in this training today. So these are some of the things that people may think of when you're saying, well, why aren't we at the end of the AIDS epidemic? You think about stigma. It's a huge stigma surrounding HIV, people who have HIV, how they contract it, and things like that. If you're thinking about illicit drug use, or if you're thinking about sexual activities, there's all these stigmas that are surrounding HIV, which makes it very difficult in certain circles to really deal with. You can also think about access. So access to health care. Some people who are in impoverished communities still, even with the Affordable Care Act, don't necessarily have the access to health care that they need. And then also thinking about access to resources. So money, where is the money going to? You're thinking about all of these grants, CDC, HRSA, all these other grants from pharmaceutical companies. where is this money going to? Is it going to communities that really need it? That's a question that we can ponder over. Next thing you can think about is why aren't we at the end of the AIDS epidemic is awareness. There are certain communities who still aren't necessarily aware of how HIV is contracted, of how HIV can be prevented. And so that kind of goes hand in hand with stigma. When people are more aware of, have the knowledge around the disease, the stigma tends to decrease. There's also discrimination. And then again, thinking about those resources that we have. One thing that we like to focus on here is the treatment cascade, and I'm sure most of you who are working in the field understand and know what the treatment cascade is. You've seen this in some form or fashion somewhere before, so I'm going to explain it really quickly. The treatment cascade basically shows us the number of people who are believed to have HIV and where they lie in the stages of HIV care. So if you look at the very left, we believe that there are 1.1 million Americans living with HIV, and at this point, only 82% of those 1.1 million Americans have been diagnosed. And then if you keep going towards the right, only 66% have been linked to care, only 37% retained in care, only 33% actually prescribed ART, which is antiretroviral therapy, and 25% have viral suppression. And viral suppression is really the key in ending the AIDS epidemic, because we know that when people who are living with HIV are virally suppressed, their chances of transmitting the disease to someone else, transmitting the virus, to someone else, is very, 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 very low. And so why is this important? We think about it as, we're not doing too bad when we look at testing and diagnosing. We're at 82%. That's not, perfect, but it's definitely not, it's not a failure. We're not failing at testing. And so when we're thinking about linking to care, we're also not doing too bad. But it's really when we get into the more biomedical, sciencey, doctor, physician areas on the right side of the treatment cascade where we start to really see the drop-off. And so one of the Black AIDS Institute's theories is that when we're thinking about testing and linking, those are activities that are done in the community. And so people are more familiar with the people that are giving them HIV tests. They're more familiar with the people that are linking them to care. They look like them. They remind them of them. And so it's a lot easier and a lot more comfortable for folks to, get on board with getting tested and get on board with getting linked. But once you lose that community connection and you start going into the biomedical aspects of the stages of care, that's when we start losing people. And so what if we could get the community, people who are working, on the front line of AIDS service organizations and community-based organizations, what if we could get them more involved in biomedical, so we can get people who are living with HIV more comfortable and more familiar with the biomedical interventions, and so that we can keep people retained, we can get them on ART, and we can get them virally suppressed. What if we had that community connection with the biomedical aspect of HIV? And so one way we have found out that we aren't where we need to be on the biomedical side of things is a workforce survey that we conducted. And so between 2012 and 2014, the Black AIDS Institute, in conjunction with the CDC, Janssen, the Latino Commission on AIDS, Johns Hopkins University, and NASDAD, conducted a nationwide HIV workforce knowledge survey. So the survey was designed to analyze the level of HIV science and treatment literacy among non-medical HIV/AIDS workforce in the U.S. And so most of you, I would imagine, that are in this room today would fall into this category. So you were eligible to take the survey. So we really looked at three areas. We looked at basic knowledge and terminology, treatment knowledge, and clinical biomedical knowledge. And so I would love to see your faces right now, but when we're thinking about how we scored, it's really not too good. And so I'm going to go to the next slide, and it's going to show you what we scored in those areas. I'm going to give you a couple of seconds to just look at these scores. So among the three categories, the HIV workforce did much better with basic knowledge and terminology. But overall, if you're looking at the purple bar all the way to the right, and we combined all questions, it's still technically what we would think of as a D. If this was an academic setting, it would still be a D. And then when you're looking at treatment and clinical biomedical interventions, those are both Fs in an academic setting. And so if we're thinking about, increasing the biomedical and clinical intervention knowledge of our HIV workforce, it's hard to do that when we don't think that we know what we need to know. So people who are working in the workforce, people who are doing testing, if our idea is that they are going to be the ones that are encouraging people to stay on their medication, that are encouraging people to keep going to their doctor's appointments and things like that, how can people living with HIV be really confident and be really assured when the workforce doesn't really know what we're supposed to know? And so that is why we're here today. I want you to think everything is really negative, because we're going to be addressing some of these issues in this training and then in BTAN in general. So these were some of the score predictors. I'm going to kind of go through this really quickly because you'll get these slides, and so you'll be able to get some of this information on your own and look over it. But if you look on the left-hand column with all the predictors on the left, you'll see that there are certain characteristics of the workforce, of people working in HIV, that told us whether or not they would have a higher or lower score. So people who had graduate educations, they on average they had 10 points higher than the average score. People who had a college degree had almost 8 points higher than the average score. And if you look towards the bottom, people who are Black or Hispanic had lower scores, and that's why their bars are going to the left. So all of the bars that are going to the left, that tells you that, whatever that characteristic is, those people scored lower. And all the bars that are going to the right, those characteristics meant that they were likely to score higher. And so I'm going to give you a couple of seconds to look at where do you fall in these score predictors. Are you is your primary role in your organization a director or manager? Because if so, then you probably would have scored about 2.6 points higher than the average. Are you a small organization? If your staff is less than 11 people, because that's an indicator that your score would have been lower than the average, 3.5 points lower than the average. If your tenure in the field, so if you've been working in HIV for more than 15 years, that tells you that your score would have been 4.6 higher than the average. And so all of these predictors kind of tell us where people would score. So think about where you would score and what work that you may need to do your job better. So again, not all is lost. We've been going around the country for the past week doing presentations in different cities on know better, do better. So our idea is, if we know the biomedical and clinical intervention information that we need to know in the HIV field, we will do better in those clinical outcomes. We will get more Black people virally suppressed. We will get more Black people adherent to their medications. But we have to start with ourselves. And so if you want more information on the survey and the full presentation, there's one available online by Phil Wilson. If you just type the hashtag know better, do better into YouTube, you'll be able to find that video. Or you can type the hashtag know better, do better into Twitter, and you can follow the various events that happened all over the country in 10 different cities all over the country, and follow the conversation that way. Or you can always type in www.blackaids.org to get more information on the HIV Workforce Survey. So now what? You have all this information about the HIV workforce not really doing as well on the survey that we conducted, and so what does that tell us? Where do we go from here? And the answer is simply BTAN. It's the reason why you're here. We have two wonderful co-chairs in the room, Jawan Pierce and Lindsay Bryant, and they're wonderful, wonderful people, and they're really dedicated to this fight, and so you're very lucky and fortunate to have them as your co-chairs for BTAN. And so what is BTAN? The mission of the Black Treatment Advocates Network is to increase patient access to and utilization of treatment and care, strengthen local leadership, and advocate for policy change in Black communities. And so we talked a little bit about why we need BTAN. You know, when we looked at the treatment cascade, we saw that only 25% of the people who are living with HIV in the country are virally suppressed. And so usually I would show that slide, and then I would show another one that shows a breakdown by race. And then when you look at that slide, you'll be able to see, on all fronts, Black people are doing worse than their white counterparts. And so we believe that that's due in part to low science and treatment literacy. And so part of this, originally when we created BTAN, we thought this anecdotally. Like, we didn't really have any evidence that people had low science and treatment literacy, except for when we did these trainings and we would take pre and post tests, and then we would get really low scores in the pre-test and then really, really high scores on the post-test, and so people were learning a lot. But when we did this workforce survey, we saw that actually people across the country don't have really high HIV science and treatment literacy. And so we know that those things, we know that low science and treatment literacy is related to late diagnosis, dropping out of care, challenges with staying adherent to medication, and higher prevalence of comorbidities, and of course the big killer, stigma. And so the objectives of BTAN are really to create a group of Black leaders in a community who will do all of these things. So we want you to serve as educators and opinion leaders. We want you to join community advisory boards. We want you to facilitate Black participation in clinical trials, increase early utilization of treatment. So for people who are living with HIV within BTAN and outside of BTAN, we want you to kind of help facilitate people using treatment and getting on treatment early, so promoting early treatment and early testing. And we also want you to improve treatment adherence and serve on decision-making advisory or planning groups, because it's really not enough to just be on the front lines. And that's great, and we need it desperately, but we also need people to be at the table making decisions, because when we see a lot of the times it's only people who don't look like us who are sitting at the table making decisions for people who do look like us. And so we need Black people sitting at those advisory and planning groups to make sure that those resources are allocated properly, to make sure that, everything is done culturally competently, and is digestible by people in our community. So this is our strategic model. And I'm not going to go through this in too much detail, but I just wanted to give you an idea that everything we do now at the Black AIDS Institute is done through BTAN. So in the green box on the left, you'll see when we start working with an organization or a group, we first want to do an assessment. So we had people who are interested in working with us take the workforce survey. And we're still doing, not a part of this survey, but just general readiness assessment. What do you know, what don't you know, and where do we need to go? So we do an assessment in the green. And so in the blue, we're either giving a group or organization technical assistance, and those are all of the things there that fall under technical assistance, or we're doing a training. And so for you right now, what we're looking at is local trainings. That's what BTAN Richmond is. And then in the red, that is BTAN. So how do we activate? So once you get trained, then we activate BTAN through these 4 project areas, and I'll talk a little bit about them, talk a little bit more about them in the next few slides. And then those are all of our BTAN chapters and targeted BTAN chapters on the far right in the brown and tan. And this is just to show you how far and wide BTAN is. We have chapters on the West Coast, a lot of chapters on the East Coast, a lot of chapters in the South. There's a few that haven't been added to this slide yet. So we're starting one in Charlotte, North Carolina, so that hasn't been added yet. And so we really wanted to give you an idea that this is not just a Richmond-Petersburg coalition. This is something that is national. It's something that you, because you're a part of BTAN, have partners in all of these different cities across the country. You have resources in all of these cities across the country. And so we really want to get that working with BTAN in different chapters, kind of collaborating and working together. So these are the components of BTAN, and I'm sure Lindsay and Jawan can do a much better job than me at explaining what they are, because they've just been working so diligently on these projects. And so I'm going to kind of go through these quickly, and then usually what we'll do is break up into 4 groups and start working on a project plan for what project you want to do that will incorporate these four components. So the first, we have treatment education, and treatment education is really important, especially for people who are living with HIV. So we want people who are living with HIV to have a better understanding of the HIV life cycle, drug classes, and all kind of the really sciencey biomedical stuff that you're learning in the BTAN training this week. And that's really important. We talked about why treatment education is important, so people understand that they need to stay on medication and what they need to do to stay healthy. So we're not just telling you to stay adherent to medication just because it sounds good. We're telling you because it's going to really change your life and change your health. The next, we have patient navigation. Patient navigation is really kind of learning how to navigate through the healthcare system. So getting people to their doctor's appointments and teaching them how to talk to doctors and ask questions that are appropriate and make sure that their doctors are treating them appropriately, how to access their new healthcare benefits if they're newly enrolled in healthcare coverage. All of those things fall under patient navigation, and that's critically important for people who are living with HIV or people who are at risk for HIV, so that they can have better relationships with their doctors, which we know that better, stronger, more comfortable relationships with doctors mean that your health outcomes are going to be much, much higher than they were. Next, we have disclosure, which is always a sensitive topic, but we really strongly believe that when people are comfortable in disclosing their HIV status, they have the power to reduce HIV stigma, right? So we're thinking about giving HIV a face. And so we don't want people to be stigmatized by their HIV status, but it's also very difficult to gain support, to gain access to care, access to support groups, or a lot of other things that people need when they're not coming out about their status and not comfortable coming out about their status. But the thing with disclosure is, you don't necessarily need to tell everyone everywhere. And so an important part of the disclosure component is that we really want to engage people in when to come out about their status, who to tell, how to tell them, and in a time that's appropriate. And then finally, thinking about advocacy. One of the things that we're really focused on in advocacy is expanding the ACA in expanding Medicaid coverage in states that haven't expanded yet. And that's critically important for people who are living with HIV. And another thing that we're really focused on is HIV criminalization for advocacy. So we're really thinking about changing those laws to make life easier for people who are living with HIV and really make their lives more healthy. So that's really what the bottom line is. It's not about comfort. It's really about living a life that they deserve to live to their fullest potential and the healthiest they can be. Well, these are our current BTAN chapters. I know I showed you the map, but I just wanted to give you a list of the different cities in case you couldn't see it on the map. The ones that are in black are the ones that have already been established, and the ones on the bottom in gray are the ones that we're currently working on and developing. And of course, I had to highlight Richmond and Petersburg. So given everything that I've said so far about BTAN and workforce knowledge and things, why do you think that Richmond needs a BTAN? I'll give you a few seconds to think about that, and then I'll get started. One of the resources that I mentioned earlier was aidsvu.org, AIDSVU.org, and they show you what the epidemic looks like down to, a zip code. And so they have a Richmond-specific slide set that is available to you. If you just go on their website and look for it, it's there. And I'll also include this with a packet of things that I'll send to Lindsay, so she'll be able to send that to you all. But right here, this shows you this data from 2011, and it shows you what the epidemic looks like in Black communities and what it looks like amongst white people. And so as you can see on the left, it's much darker, which means there are much higher rates of HIV among Black people in Richmond and in the surrounding areas than there are among white people. And so going back to the question, why does Richmond need a BTAN? It's because of this disparity that we're seeing right here. But we really want to focus on how do we get the people who are most affected by HIV, how do we get them into care, how do we keep them in care, and how do we get them virally suppressed? And BTAN is the way to do that. It's really about making a strong coalition in the community and developing projects that are attractive to people who are living with HIV, people who are at risk for HIV, and even people who aren't necessarily at risk. Making these programs attractive enough so that people get engaged and they become more passionate and more invested in ending this epidemic in their communities. And I know particularly it's important in Richmond, and particularly important in Petersburg as well, when we think about the resources that are available to Black organizations. They're limited. And so we really want to think about what are some creative and innovative ways to get people in the surrounding communities engaged with BTAN and engaged in doing this important work that you all do. And just to clarify, the gray areas are not areas that don't have any people living with HIV. It's just that the numbers are so low in those specific areas that AIDSVU, in order for confidentiality reasons, has decided not to show those numbers so that people can't necessarily be pointed out. So that's really about confidentiality and protecting people's privacy, not that there aren't any people living with HIV yet, just to be clear. And so that sums up my presentation. Here's my email if you want to contact me, Rebekah@blackaids.org. And again, I'm the Training and Evaluation Coordinator. But really what I wanted to get across to you all today is that we need you. We need you here in this room. We need you moving forward, working with BTAN Richmond and Petersburg to get people engaged, to get people in care, to get people more aware of what HIV is doing to their communities. Because we find that a lot of people just don't know or just don't care. And so let's try to think about some creative ways to get people more aware and more passionate about these issues. So again, if you have any questions, I'm sorry I'm not there to answer them, but I'm pretty responsive on email. So if you can just shoot me an email or ask Lindsay the question or Joanne, and they'll get that question to me, and I'll try to respond as soon as possible so that we can really move forward with this. So good luck. Thank you for being here. Thank you for giving your time for 3 days. I know all of you are really busy with work and school and children and other responsibilities that you have. So we don't take it lightly that you're here trying to better your community. So thank you and have a nice day.